Next, I am going to go to one of my favorite portions of the conference, which is the Luella Klein Lectureship series. Dr. Klein was a lifelong, passionate advocate for women and their babies, and the providers that care for them. In 2018, the GOGS Foundation established the Luella Klein Lectureship in honor of her contributions. Dr. Klein graduated summa cum laude from the University of Iowa with a BA in 1946 and received her medical degree in 1949. She completed her training in internal medicine and then general surgery prior to completing her residency in OBGyn at Case Western in Cleveland in 1955. After residency, she was selected as a U.S. Senior Fulbright Scholar and studied at the University of London. In 1986, Dr. Klein became the first female department chair at Emory School of Medicine and would later hold the title of Charles Howard Candler Professor. Dr. Klein's subspecialty in MFM served as the foundation for her work as the director of the Maternal and Infant Care Project that's located at Grady and services to this day. Throughout her 60-year career, Dr. Klein championed for equality in health care for adolescents, low-income, and incarcerated women of color, women with disabilities, those with HIV, and other underserved populations. She was noted for her teaching abilities and her excellent clinical judgment. Dr. Klein has numerous other accolades, including being the first female president of the American College of OBGYN and the 25th president of the GOGS. Dr. Methodius Tuuli is a much-deserved recipient of the Luella Klein Lectureship. Dr. Tuuli, a board-certified MFM specialist, is professor and chair of the Department of OBGYN at Brown University. He is better known as Method or Method Man to us who know him very well. Dr. Tuuli graduated from the University of Ghana. He received his MPH at the University of California at Berkeley. Following that, he completed his residency in OBGYN at Emory, where I was fortunate enough to have him as my upper level. He completed his MFM fellowship at WashU in St. Louis, where he remained as a faculty member for a number of years. His research is focused on the prediction and prevention of adverse OB outcomes, including preventing surgical site infection after cesarean, the management of labor, and optimizing management of medical complications in pregnancy. Among his numerous awards are the 2014 Roy M. Pitkin Award for Outstanding Article in the Green Journal, the Research Excellence Award by the Gray Journal, the President's Award from the American OBGYN Society, or AGOS, and multiple Best Oral and Best Poster presentations for multiple years at the annual SMFM conference. It is with great honor that I introduce my friend and amazing MFM, Dr. Methodius Tuuli.
Thank you so much, Champa, for the invitation to speak here today. And thank you, Georgia OBGYN Society, for the opportunity to be at this meeting. This is my second attendance of this meeting, and I enjoyed the first one very much, and I'm enjoying this as well. So, wanted to go through some memory lane. This is our intern picture at Emory. I was the only male in the class wearing the white shirt, innocent, you may say naive, and optimistic about life. I had the privilege of knowing Dr. Klein. She staffed our MFM clinic, and I also had the pleasure of accompanying her to Georgia OBGYN Society meetings in Atlanta during the time she was a little more frail to make sure she was okay. She was a person of grace and dignity, intellect, and she was squarely focused on equity. And if we could all be half of what she was, I think the world would be a better place. This is the Emory OBGyn department when I was in 2007, when I was about to be chief, and many of the people in this audience are in this picture. I see Champa right up there. I see Dr. Span, many people. And, I must always say, Dr. Lindsay, I owe a debt of gratitude to Emory for giving me the opportunity to train in the US. They gave me a chance to this black boy from Ghana who they didn't know anything about. And so I will always cherish that. And this is Dr. Span, and I don't know if he remembers this, but he would call me up on a Saturday. He knew my name was Methodius, but he called me Demetrius. So he will say, Demetrius, do you want to operate? And I will run into Emory Midtown and have the pleasure of learning to do surgery. In fact, his influence made it difficult for me to select MFM as a subspecialty. But I still teach everything that he taught me to my residents. And the other piece I'll add is when he asks you to find the ureter, he will be counting 1001, 1002, 1000. And he didn't want you to get to 1005 before you found the ureter. All right, so with that, let's some disclosures. I'm lucky to get money from the NIH and from the Gates Foundation to do clinical work that I enjoy. I did not know that I could make a research career out of doing bread and butter, answering bread and butter questions, but I've been lucky to be able to do that. I also partner with industry because they manufacture the products and the medications that we use. And although it's controversial, I will say if we do not partner with industry, someone will, and maybe the outcomes will not be what we want. So for the purposes of this talk, Pharmacosmos manufactures IV iron medications, and they are donating products for this trial. So at the end of this, I want to review some of the pathophysiology of iron deficiency anemia in pregnancy. I want us to review some of the risks and benefits of oral versus IV iron. And then I want to present some ongoing trials, which I think will provide data for practice. The reason I like to live at the interface of research and clinical practice is that, guidelines are changing all the time. And without a foundation of the data preceding and the data coming forward, then we begin to feel that we just keep changing, but there's a method to that madness. And so I like to provide all of us a foundation for that. So these are the different sections that we are going to go through. Start with an overview of iron deficiency anemia in pregnancy, look at the pros and cons of oral versus IV iron, and review 2 trials that we conducted or are conducting on the subject, and then give some take-home messages. All right, so 2 blood smears of normal versus iron deficiency, hypochromic and microcytic, as we can see over there. But I started being interested in iron deficiency because, you go to board, sign out, and then, the resident will say, hey, hemoglobin is 9, and she's on oral iron, moving on, as though that were just normal. And so I found that, and I'll call it probably the most common and also undertreated or untreated condition in pregnancy. Iron deficiency accounts for the biggest proportion of it, depending on your population and the existence of other hemoglobinopathies. It may be up to 80 or even 95%. What is the prevalence of iron deficiency? This study by the WHO in 2011 suggested that nearly 40% of the global population has iron deficiency anemia. In the US, data from the CDC suggests that the number may be around 19% for iron deficiency and about 17% for iron deficiency anemia. So the sequence of events is reduced iron stores, which is iron deficiency, and when that is low enough, then anemia then develops. The prevalence, as you can imagine, varies with the trimester of pregnancy, being lower in the first trimester and increasing towards the end. And I always tell the residents that 1 in 3 pregnant people are anemic by the time they come to labor and delivery. Unfortunately, as with many conditions in pregnancy, disparities exist with black and brown patients having a higher prevalence of iron deficiency anemia in pregnancy. So a review of the pathophysiology. Part of the pathophysiology of anemia in pregnancy is dilutional. As we all know, plasma volume increases by about 50%, red cell mass increases by about 25%, so there's a physiologic component to the anemia as well. In terms of iron requirements, a good rough number that every pregnancy needs about 1,000 milligrams of elemental iron. About half of that expands the red cell mass, about a third of that goes to the fetus for stores, and about another third accounts for blood loss at the time of delivery. And one of the reasons iron deficiency anemia is a problem, especially in pregnancy, is the absorption of iron. So about 1 milligram of iron is absorbed per day because there's a tight regulatory system in the gut to regulate absorption of iron. And that iron goes in, is bound to transferrin, is stored in the reticular system, and then is broken down back for red blood cell synthesis. So because the daily requirements of iron exceeds the dietary capacity, especially towards the end of pregnancy, pregnancy is really primed for iron deficiency anemia. So what about definitions? We keep having mixed definitions. So the WHO describes anemia in pregnancy as hemoglobin less than 11 or hematocrit less than 33%, irrespective of the trimester. The CDC is more nuanced, having a different number for first versus second versus third trimester. We can also talk about anemia in pregnancy in terms of severity, 9 to 10.9 being mild, moderate 7 to 9, and more severe, less than 7 grams per deciliter. There are well-known maternal consequences of anemia in pregnancy. So one systematic review suggested that having anemia during pregnancy increases the odds of pregnancy by 2 to 3-fold. There are other things that come with that, the need for blood transfusion, sepsis, cesarean delivery, even maternal mood disorders. And one that is particularly interesting is the fact that patients who are anemic are more likely to have postpartum hemorrhage, which worsens their plight. But also interesting is the effect of anemia on the fetus and on the offspring. So there are many conditions, including preterm birth, low birth weight, iron deficiency as well, that have been associated with mothers who are with fetuses of mothers who had anemia. But increasingly, what is attracting me to this work in particular is the consequence of iron deficiency in the mother on the offspring. So the studies suggest in the pediatric literature suggest that iron deficient moms are more likely to have iron deficient neonates and offspring. And even if you replete iron post-delivery, you never get them back to what they needed to be because there are processes which are important, which need iron even before these babies are delivered. So one Swedish study of nearly 500,000 patients, they have these that large electronic databases, and they show that in general, babies of pregnancy of moms who had anemia before 30 weeks gestation had a higher rate of neurodevelopmental and behavioral conditions. This other study, which is interesting because of the length of follow-up, 19 years, they followed 185 patients over 19 years, and showed that if they had anemia when they were born, for more than 3 to 4 months, impaired cognition continued into adulthood. So it's, going back to the intrauterine origins of disease, it's really interesting that something like that could have such a long-lasting impact. So animal studies suggest a causal relationship between iron deficiency and neurodevelopmental outcomes. It is shown that iron deficiency results in impaired myelin formation, which is the white matter of the brain, dendritic growth, and synapses that need to be formed. This is a study from an animal model, and the point I want to show here is that if we look at This is total brain volume, gray matter and white matter, that for this animal model, the animals that were anemic during pregnancy, there was a statistically significant difference in the total brain volume of their neonates, and that applied to both the gray and the white matter. Some studies suggest one or the other, but it is really remarkable that anemia, which we all mentioned at both sign out and keep moving, could have an impact on structural brain volume. This is a study from Brown University. It wasn't directly a study of iron anemia in pregnancy, but it was a study of delayed versus immediate cord clamping. And as we all know, delayed cord clamping results in a better iron load for the neonate. And they showed in this study that significant parts of the brain, including internal capsule and these others listed here, had a lower volume in the babies that had immediate cord clamping versus those who had delayed cord clamping. And they also showed that there was a correlation between iron stores in these offspring and these brain volumes, which is just intriguing as an effect. So how do we diagnose and prevent and diagnose iron deficiency anemia? So prevention is a better strategy, and we all know these primary preventions: optimize iron stores before pregnancy, and then spacing pregnancies also help. And then prophylaxis during pregnancy. So most of our prenatal vitamins will contain, low levels of iron, and that has been shown to reduce the risk of anemia later by up to 70%. The U.S. Preventive Task Force still says that all the studies to date show an effect on hematologic measures, but really not on other clinical measures. Diagnosis. So we all know anemia when we see it, a CBC, and with hemoglobin, hematocrit, that meets the criteria that we listed earlier. An important difference in practice, though, is that many people do not do a complete workup for anemia. ACOG is to blame to some extent, because the practice bulletin says because iron deficiency anemia is the most common cause, we could consider presumptive treatment, which works great for most patients, but especially in populations where there may be lots of underrepresented minority, there are other hemoglobinopathies that may be the underlying cause, and giving iron may actually be the wrong treatment in those patients. So I am a big advocate of diagnosis before treatment. We send a CBC, it comes back suggestive of anemia. We at least start with the most common cause, ferritin, and then go from there to look for other conditions as well. Ferritin is as a single measure. There are others like total iron binding capacity and all, but ferritin is the single most important measure for iron deficiency overall. And a cutoff of 30 nanogram per deciliter is both sensitive and specific. 92 and 98% respectively. So we've now diagnosed anemia in pregnancy. What do we do? So oral iron may be an option, parenteral iron, mainly IV, and blood transfusion. So there are different formulations of iron. These are some of the most common, and there are more modern formulations which are more expensive, but which have not been conclusively demonstrated to be better than these. It's always important to know that there's a difference between the total tablet size in milligrams and the elemental iron. You really want to have your eye on the elemental iron because that's what is important here. So what are the pros of oral iron? If it's taken, and that's a big if, it is effective if it's taken. There are, of course, low rates of severe adverse effects, although like GI effects are very highly prevalent, and it's cheaper if you just consider the medication alone. But there are also drawbacks. Up to 70% of patients have significant GI symptoms that lead to non-compliance with taking those medications. You need to treat for a really long time, even after anemia is resolved, in order to have sufficient iron stores, and it may not be sufficient for severe anemia. It's also important that absorption of iron is tightly regulated, and as a result, you may be taking the iron and actually not getting the benefit. Well, can we do better? Can we optimize oral iron as a way of treatment? So, as I noted, newer formulations claim to have less side effects and probably better absorbed, but the data are not exactly clear on that regard. An important strategy is intermittent dosing. So there have been many studies that have looked at every other day dosing versus daily dosing, and the general effect is that you have less side effects, but with equivalent efficacy. So that is an important strategy that we can use if we are going for oral iron. Hepcidin is the molecule in the gut that regulates absorption of iron. Some studies have used the level of hepcidin to decide on dosing, but those studies generally suggest that it is not more effective. It may result in you taking less iron and therefore less adverse effects. So what about parenteral? So there are studies, believe it or not, on IM iron. Don't do it. It's painful and it leaves discolorations on the skin. So IV iron is what we will be talking about today. The benefits are that you put it in there if you give a patient IV iron. So compliance is not an issue. You can give, at least for some formulations, the total replacement dose of 1,000 milligrams all at once, which is cost efficient. And then GI side effects are not an issue with parenteral IV iron. But there are also downsides. I was chatting with somebody yesterday who mentioned their patient having DVT after receiving IV iron. It does happen. Fortunately, it's not extremely common. And also, there are the rare allergic anaphylactic reactions, and maybe the more experienced providers maybe remember the days of high molecular weight dextran, where anaphylaxis was common, and some of that legacy follows up to today, which leads to reluctance in thinking about IV iron. It requires logistics. I don't know about your hospitals, but our infusion center will rather give chemo, which comes with a higher margin, than give IV fluids or parenteral iron. And then the initial cost is higher, although if we prevent transfusion in the long term, it may be cost effective. So just to introduce the different IV formulations for iron, all of them, most of them consist of an iron core, which is then surrounded by a carbohydrate. And the reason is not to expose the iron to the blood vessels, because that's what leads to injury and allergy and so on. More recent formulations is a polymer into which the iron molecules are actually embedded. And the name of the carbohydrate shell is what gives them their different names. So the different formulations have different carbohydrate shell. So this is a table that summarizes them. I like to think about them in terms of what the concentration is, whether you can give a total infusion or not, because that's important, and then the recommended dose. So iron sucrose has been there for a long time. Its downside is that you have to give repeated doses in order to get the full dose, and therefore there could be logistical challenges. Ferric diisomaltose, also called monoferric, can be given as a single infusion. And then so is ferric low molecular weight iron dextran. So remember, high molecular weight dextran is the one that had the high rate of allergic reactions. This is relatively safer and probably the cheapest as well among these. All right, so there are some challenges why IV iron is not as common as many people think it should be. So the first is that once bitten, twice shy. We are all very conservative, and we don't want to expose our patients to potential severe allergic reactions. ACOG has been very conservative in its recommendation of IV iron, still recommending that oral iron, and I agree, be the first line, and for IV iron to be a second line for those who cannot tolerate oral iron or for some other reason cannot take it. But a significant barrier is that there are no good data, especially in the US, on the role of IV iron. And we're going to review some of that. Most of the studies come from low-income countries, and there may be some reasons why those data may or may not be translatable to the US. And there are cost considerations, as I noted earlier. So we did a systematic review to look at the role of IV versus oral iron, and this started off when we asked a fellow to help develop a protocol when I was in St. Louis. And he comes to present this protocol, and we all agreed that the data in support of it were so limited. So we decided to do a formal review. So we identified 20 randomized trials, and the bottom line summary is as follows: that if you use IV iron, in 4 to 6 weeks after you give that, there was a 0.66 grams per deciliter. Note, this is not a relative risk or odds ratio. It's actually the measure, meaning there's a less than 1 gram per deciliter difference in hemoglobin for patients who had IV versus oral iron. There was a significantly heavier babies, but by only 58 grams, which may not be clinically significant. But it was clear that there was no difference in adverse events if we counted all of them. But GI tended to be more common in oral, and more systemic adverse events tended to be more common in IV. But we realized that the studies were very heterogeneous. They were all over the place, different formulations, infusions at different times. The outcomes were different. The sample sizes were small overall. At the time, the largest study was 252, and they did not evaluate clinically relevant outcomes. And nearly all of them were done outside the US. So we concluded that IV iron may be associated with slightly higher levels of hemoglobin with generally mild adverse events, but the data were limited. And soon after that, while we started doing our own work, this study was published in the Lancet from India. They randomized nearly 2,000 patients at 4 centers with moderate to severe anemia at 20 to 32 weeks, and they received IV iron sucrose, those who were randomized to IV iron, and because they needed anywhere from 1 to 5 infusions, the patients received different doses of IV iron. The oral iron group received iron sulfate. It was 100 milligrams 2 times a day. Their primary outcome was a maternal composite of adverse events, which they thought was related to anemia. And it was 9% in the IV iron group and 10% in the oral iron group. The adjusted odds ratio suggested that there was no significant difference in their primary outcome for IV versus oral iron. They looked at other outcomes, and there was not much difference between the two groups. Severe anemia was less likely in the IV iron group, but all the list of large outcomes were all relatively similar. So it was concluded that there's insufficient data on the effectiveness of IV versus, or at least IV iron sucrose versus oral iron in reducing adverse pregnancy outcomes. So there was an accompanying editorial which said the jury is still out on IV versus oral iron, and this for me underscores something really important. There are many aspects of clinical practice which we must use our judgment, but there are some policy questions which I believe really need to be subjected to rigorous study, because sometimes what I think will definitely be the case is not borne out by the data. But it is possible that because they required multiple transfusions, patients were not adequately in the IV iron group repleted. They reported a 96% rate of moderate to good compliance of the oral iron. I'm moving to India. So it is possible that because these patients were so compliant in the oral iron group that they had the benefit, and that's why it wasn't different compared to the IV iron. So it is, I think the jury is really stood out, which is the foundation for the work that I'm going to present. So AVIDA-1 was the pilot study we decided to do as a result of reviewing the data in the systematic review and finding that there were no good data in the US. So AVIDA-1 was the first randomized controlled trial of IV versus oral iron in the US. So we randomized patients in this pilot study to IV or oral iron if they remain anemic at the 24 to 28 weeks when we repeated their CBC with their 1-hour glucose tolerance test. And those who were randomized to IV iron had 1,000 milligrams of low molecular weight iron dextran, and those in the oral group had iron sulfate. Our primary outcome was resolution of, or anemia, persistence of anemia at the time of delivery, and we had a list of secondary outcomes. So we started with 55 patients who were consented, 55 patients, consented 38, randomized 18 and 20 in the two groups respectively, and we learned a bitter lesson. 5 patients in the oral group decided that they didn't want the oral, they wanted IV after randomization, and 10 patients in the IV group decided that, never mind, I'll continue my oral iron. So we learned a lesson for the definitive trial I'm going to talk about. So at the end, we had 18 patients and 10 patients in the groups where we had outcomes. Baseline characteristics were similar between groups, meaning the randomization worked even after the exclusions. And this is the mean hemoglobin between the two groups. So oral iron, the average was at 9.9, and for IV iron, it was around 11. Although they're different, right? They are statistically different. But I'm still amazed that after all that work, what we got was a difference between 10 milligrams per deciliter and 11 milligrams per deciliter. So we looked at the primary outcome, which was persistence of iron deficiency anemia, and 85% of those who were on oral iron remained anemic. And that's not surprising. If you started off anemic and we kept you on the treatment that you were either not taking or wasn't working. And then 40% of those in the IV were still anemic. The point there is that even after putting it in the veins, we knew we did that. 40% were still anemic at the time that we delivered them. And for severe anemia, it was 10% for IV iron and 54% for oral iron. We looked at other outcomes, which were quite interesting. So blood transfusion, all the 2 cases of blood transfusion occurred in the oral iron group. There was none in the IV iron group. In terms of neonatal, there were no differences in hemoglobin for the baby, although there was slightly higher ferritin, meaning the iron stores were better in the IV iron group, the babies in the IV iron group. So we concluded that a randomized trial of a single dose of 1,000 milligrams IV iron versus oral iron is feasible in the US, and that these initial results are promising for a definitive trial. So we proposed this trial, and we were lucky to be funded by the NIH to do this multi-center trial in the US. So we are currently conducting the first definitive double-blind multi-center randomized trial of IV versus oral iron at 3 medical centers to test the hypothesis that giving IV iron improves pregnancy outcomes, including blood transfusion, and importantly, looking at those offspring outcomes. It's our protocol paper, and so our primary outcome will be focused on blood transfusion, peripartum blood transfusion. Secondary outcome will look at cost effectiveness between the cost effectiveness of IV iron, and then we'll look at offspring outcomes. So this is a little more detail about the study, but at the end of the day, patients randomized to IV iron will receive ferric diazomaltose, 1,000 milligrams, and those on the oral iron group will have iron sulfate. These are the sites. The studies are in St. Louis, at WashU, at Michigan, and at Brown in Providence. We are also collaborating with the Children's Hospital, where we are going to look at the baby outcomes. Oral iron, I didn't know that manufacturing placebo could be such good business, but the University of Iowa is giving us the placebo tablets, and they are expensive. But I think it's important if we are going to have a definitive answer to this question. This is how we are blinding patients. So all IV bags are covered with this opaque tubing, and then we put a bandage at the point where the IV is going in. So everybody receives an IV. If you are in the oral iron group, you have 500 milligrams of saline, and then you take active iron pills. And if you are in the IV iron group, you get 1,000 milligrams of iron, and then you take placebo until delivery. So this is how we are going to march down this. We test you at the beginning. We repeat your testing with your 1-hour glucose challenge test. You are randomized, and we move on to assess outcomes. So our primary outcome is blood transfusion in the peripartum period. We think it's clinically significant because blood transfusion is a big deal, both in access as an issue itself and all the other things that go around with it. In most studies, over 90% of patients who have a blood transfusion after delivery tend to have it within 7 days. So that's why we limited it to 7 days. We're going to collect a large group of secondary outcomes, including looking at maternal depression, as many studies are suggesting that it may be resolved with IV iron. Analysis, standard analysis intention to treat, our sample size sufficient enough for us to find a significant difference in blood transfusion. And then we'll look at cost effectiveness. So we are going to say, given the cost and logistics of IV iron compared to the logistics of oral iron, and the benefits and costs associated with the downstream effects, which overall is more cost effective. But what I'm even more excited about are the babies, the baby outcome. So at 4 to 6 weeks, we are going to do weight, iron status of the babies, and we're going to do MRIs of those babies' brains to quantify the level of myelin in the baby's brain in collaboration with our collaborators at the Children's Hospital. We're also going to do EEGs on the baby's brains, and then we'll do developmental assessment. So that allows us to look at the structure with MRI, electrical connectivity with EEG, and function with the neurodevelopmental assessment. There are many, many studies that are out there now collecting data on IV versus oral iron. Nearly all of them are outside the US. Ours is probably the only definitive trial in the US, funded by the Gates Foundation and some foundations in the UK. I think those data will start coming in fast and furious. In fact, one of them came out recently, the REVAM trial, which in Malawi, which did not show any differences between IV and oral iron in terms of the primary outcome that they assessed. Going back to my thought that, as a policy change, it makes common sense to think that IV iron would be better, but I think the data are giving us reason for caution. Remember amnioinfusion for meconium stain liquor? Many of us got splashed with that fluid when we used it in meconium stain liquor. It makes all the sense. Put it in there, wash it out, but we found out later from a definitive trial that that was not the case. There's an upcoming symposium to review all the data for the US and make some recommendations. I think many will say for patients who are not tolerating oral iron, you should consider IV, but I worry that a whole scale move towards IV iron, especially for those who are pushing it as the first line, may be premature. There was that paper in the Green Journal in June. Dr. Ayobak is a consultant for our trial, but he will give IV iron to anybody, any day, any time. So he was writing a commentary in response to a feasibility study, and yet he concluded that it's time to change to IV iron. There's probably better data for postpartum, which is what that feasibility study was about, but I would say exercise caution. So what should we be doing? I think iron deficiency anemia, we should pay attention to it. It is common, it's undertreated, and it's having impact beyond just the mother. And if at all it's true that iron deficiency has those effects on the structure and function of the brain, and we know that there are these disparities in the prevalence of iron deficiency, it could be a public health opportunity to close the gap in many things by making sure that pregnant people are adequately treated. The current treatment paradigm is suboptimal since 1 in 3 pregnant people are still anemic when they come to the hospital. Oral iron should be used routinely for prophylaxis. We should consider intermittent dosing every other day, maybe reduce adverse events and not impair effectiveness. IV iron, the current data are limiting based on everything I've reviewed and everything that is coming in so far, but there are ongoing studies that are promising and will give us definitive data. The challenge of changing practice before the studies is that, one, you make it difficult to study, and then we have to go back when the data come in, if they don't support what we are already doing. So I show this picture not because my family is cute, I think they are, but my wife was anemic with the little girl, she was prescribed oral iron. I know she didn't take it. And she's running the household at the age of 2, so the jury is still out there. Thank you.